discuss femoral vein. All these you have read already during your theory individual classes. So we have put it together, the applied aspects only. So femoral vein is this is the femoral vein you can see here. It is upward continuation of the popliteal vein at the lower end of adductor canal through the adductor hiatus, and it continues upward as external iliac vein behind the inguinal ligament. And these are the tributaries: great saphenous vein, medial lateral circumflex femoral vein, deep external pudendal vein, profunda femoris vein, vein accompanying the muscular branches of femoral artery, and formative tributary is the popliteal vein. So what does these two terms mean? Superficial femoral vein artery and deep femoral artery. Okay, so some surgeons refer upper part of femoral artery up to the beginning of profunda femoris artery as common femoral artery, and that divides into superficial femoral artery and deep femoral artery. Superficial femoral artery is remaining part of femoral artery, and deep femoral artery is profunda femoris. Okay, these terms are also used in your question. If a long question comes from those femoral artery or femoral vein or femoral sheath, these terms are also used. So you have to understand deep femoral artery means profunda femoris artery, okay, and superficial femoral artery means femoral artery, and common is the main trunk before giving the branch. Now, femoral vein is commonly used for intravenous infusions in infants, children, and in patients with peripheral circulatory failure. Okay, this comes as explained why question why femoral vein is used, but it is easily accessible. Okay, easily accessible deep vein. Okay, generally we do infusion in peripheral veins, but in circulatory failure peripheral veins are collapse. Next we go to right heart catheterization. Femoral vein, all these I am discussing today comes as explained why question mainly. Okay, the clinical aspects. So why femoral vein is used in right heart catheterization? It can come as explained why. Femoral vein is also used for right heart catheterization. Catheter inserted from femoral vein following this route. First we go through the femoral vein, then external iliac vein, common iliac vein, inferior vena cava, right atrium, right ventricle, pulmonary trunk. Up to this level we can go from the femoral vein. We can pass the catheter. Okay. Here within the right atrium, then through the tricuspid valve enter the right ventricle. From the ventricle through the pulmonary valve you can enter into the pulmonary trunk. Next is deep vein thrombosis and pulmonary embolism. The deep venous thrombosis is formation of blood clot in the deep veins, and such clots formed in femoral vein gets separated and may enter in the circulation and reach in the vessels of lung, where it causes pulmonary embolism or blockage of the pulmonary vessels. Very fine vessels are present in lung, that's why the clots are trapped there. Okay. Also, there are fine vessels in our brain also. There also embolism can occur. Okay. Next we go to femoral nerve and its applied aspect. See here, this is the femoral nerve. It is a branch from the lumbar plexus. So femoral nerve is chief nerve of anterior compartment of thigh, largest branch of lumbar plexus, and lumbar plexus was lying within the substance of psoas major muscle. Okay, you have read previously. So femoral nerve is largest branch of lumbar plexus, arises from dorsal divisions of ventral primary rami of L2, L3, L4 spinal nerve. This is root value L2, L3, L4. Length is 2.5 centimeter in the thigh. So this is the course and relation. In the abdomen, it begins on the posterior abdominal wall, emerges out along the lateral border of psoas major muscle and runs further downward on the iliacus under the cover of fossa iliaca. Okay, emerges out along the lateral border of psoas major. This point is important during identification of femoral nerve in posterior abdominal wall dissection. Okay. Next, in the thigh, enters the femoral triangle by passing behind the inguinal ligament just lateral to the femoral artery. Okay, nerve is outside of the femoral sheath. Okay, this is not included within femoral sheath. And femoral nerve lies outside the femoral sheath because it lies posterior to fossa iliaca, which forms the posterior wall of the femoral sheath. And at about 2.5 centimeter below the inguinal ligament, femoral nerve divides into anterior and posterior divisions. Lateral circumflex femoral artery passes in between the anterior and posterior divisions of femoral nerve. These are the branches in abdomen and in thigh. In abdomen, it gives muscular branches to the iliacus and pectineus. Okay, this is schematic diagram. Femoral nerve can come as a long question, part of a long question. Okay, so we have to know the branches. In the thigh, anterior division gives muscular branch for sartorius, only one muscular branch from anterior division, and rest are cutaneous branch. Two cutaneous branch, medial cutaneous nerve of thigh, intermediate cutaneous nerve of thigh. Posterior division, it has muscular branches for four muscles of quadriceps femoris. Okay, rectus femoris, vastus medialis, lateralis, intermedius, and articularis genu through branch of vastus intermedius. And cutaneous branches, here only one cutaneous branch, saphenous nerve. এটা খুবই ইম্পর্টেন্ট femoral nerve branches asked in your viva, OSP, theory, everywhere it comes, femoral nerve. Its root value and branches are very important. Okay. And articular branches is nerve to rectus femoris supplies hip joint, nerve to vasti supply the knee joint. And lateral cutaneous nerve of thigh is a separate branch of lumbar plexus. Here the branches have been shown. Three vasti, articularis genu, rectus femoris, it is giving branch to hip joint, and articularis genu, this is giving branch to knee joint. Okay, and this is saphenous nerve, only cutaneous nerve. All these are branch of posterior division. Here anterior division, only muscular branch is sartorius, and these two are cutaneous branch, intermediate and medial cutaneous nerve of thigh. Okay, and these two branches coming from the main trunk, pectineus and iliacus. Understood? A root value you can see L2, L3, L4. So femoral nerve injury, it may result due to wounds in the groin and result in paralysis of quadriceps femoris, sensory loss over the anterior and medial side of the thigh and medial side of the leg. Okay. So if you know the branches, you can assess. Then femoral nerve block. Local anesthetic, how this block is given in lower limb surgery. Okay, when general anesthesia is not used, only some part surgery is needed in the lower limb, this femoral nerve block is given. Okay, so local anesthetic agent is injected around the femoral nerve to achieve the anesthetic effect, and that blocks nerve conduction by inactivation of the sodium channels, and it is available as gels for local applications or injections for nerve block. Okay, that's how the nerve block is given. Next, adductor canal. Okay, in the adductor canal, John Hunter first performed. Here we ligate the femoral artery. Okay, that's why adductor canal is important. So John Hunter first performed ligation of femoral artery in the adductor canal for the treatment of popliteal artery aneurysm. That aneurysm means abnormal dilatation. Next is adductor canal block. Local anesthetic is injected in adductor canal to block the saphenous nerve. Okay, saphenous nerve is a content of adductor canal. You have read. Adductor canal compression syndrome. There is hypertrophy of the adjacent muscles. Its boundary is formed mainly by the muscles. You have seen sartorius, vastus medialis. All these are forming its boundaries. So hypertrophy of adjacent muscles may cause compression of neurovascular bundle in the adductor canal, and it may result in claudication symptoms due to femoral artery compression or neurological symptoms due to saphenous nerve compression. And claudication is pain, numbness, or tiredness in the legs during walking or standing. Okay. So this is summarization of femoral nerve. Beginning arises from dorsal division of ventral rami of L2, L3, L4. These terms are important. Coming from dorsal division of ventral rami. Okay. Asked in your viva actually all these or comes in MCQs. Course enters in femoral triangle deep to inguinal ligament, lateral to femoral artery and femoral sheath. These are the branches. Main trunk in abdomen gives branch to pectineus ciliacus, anterior division muscular branch to sartorius, cutaneous branch to medial cutaneous nerve of thigh, intermediate cutaneous nerve of thigh. Posterior division muscular branches to rectus femoris, 3 vasti, articular is genu, cutaneous branch is saphenous nerve, articular branches to hip and knee joint. And femoral nerve is the largest branch of the lumbar plexus. Okay. And clinical integration, nerve injury leads to paralysis of quadriceps here and loss of sensation along the medial side of the thigh and leg. These nerves are lost. And femoral nerve block you have seen. Next is muscle transplantation. Okay, gracilis muscle is used. This is one of the adductor muscle, adductor group of muscles you have seen. Three adductor longus, brevis, magnus and gracilis. All these four are included in adductor group of muscle supplied by the obturator nerve. Okay, so gracilis muscle can be used as muscle transplantation, commonly used for muscle transplantation or reconstructive surgery. Flap is utilized and this flap consists of gracilis muscle, its arterial supply by branch of medial circumflex femoral artery and its nerve supply branch of anterior division of obturator nerve. And gracilis is also called custodian of virginity. Okay, lies on the medial aspect of the thigh. Next is obturator nerve. So we have discussed clinical aspect of femoral nerve. Okay, obturator nerve is the main nerve of adductor compartment of the thigh. Obturator nerve, it root value is also same, but it is a branch of lumbar plexus, but it is formed by ventral division of anterior primary rami. Femoral nerve was dorsal division. Okay, here it is ventral division. This difference points you note. Okay, this comes in your viva and MCQ, important for your. So obturator nerve is branch of lumbar plexus formed by ventral divisions of anterior primary rami of L2, L3, L4 spinal nerves. Okay, here is the obturator nerve. It is dividing into anterior and posterior divisions. In the pelvic cavity, the proximal or upper part of the nerve lies in the abdominal and pelvic cavity and nerve emerges out through the medial border of psoas major. Okay, femoral nerve was emerging along the lateral border and this obturator nerve is emerging along the medial border of the psoas major. That's how you identify these two nerves in dissection and passes downward behind the common iliac arteries. In the thigh, obturator nerve enters the thigh through obturator foramen while passing through obturator canal and divides into anterior and posterior divisions. Anterior division passes downward in front of obturator externus. Further, the nerve descends behind pectineus and adductor longus in front of the adductor magnus. And posterior division passes through the substance of obturator externus muscle in the thigh. So this is the course of obturator nerve, and this is division of abdominal aorta. It divides into two common iliac artery. Each of the common iliac artery then gives rise to external and internal iliac arteries. External iliac artery again continues as femoral artery. Here you can see obturator nerve. This is anterior division. This is posterior division. Okay. Posterior division, this is giving branch to obturator externus and lying between the adductor brevis and magnus. And here is anterior division, lies giving branch to pectineus and supplying the longus, adductor longus, gracilis and giving a branch to subsartorial plexus of nerves. And here it is posterior division is continues as genicular branch supplying the cruciate ligaments of the knee joint. Anterior and posterior cruciate ligaments are there, and sometimes one accessory obturator nerve is present and it mainly supplies this pectineus muscle. Okay, understood? Okay, so these are the branches you can see. Anterior division supplies the adductor longus, gracilis, pectineus, brevis. Maybe brevis is maybe supplied by posterior division, and hip joint and branch to subsartorial plexus in the adductor canal to supply the femoral artery. Posterior division pierces the obturator external muscle and supplies obturator externus, adductor magnus, adductor brevis if not supplied by anterior division, and genicular branch for the popliteal vessels, cruciate ligaments and capsule of the knee joint. So these are the branches of the obturator nerve. Okay. So formation, anterior division of ventral primary rami of L2, L3, L4. This is the main nerve of adductor compartment. Root value L2, L3, L4 branches anterior posterior division. This is the distribution. Anterior division supplies pectineus, adductor longus, gracilis, brevis if not supplied by posterior hip joint subsartorial plexus, and posterior division supplies the obturator externus, magnus, brevis, genicular branch of knee. Okay, so how will you find in dissection? This posterior division is lying between the magnus and brevis. Okay, and anterior division is lying between adductor longus and brevis. Okay, that's how you identify these two divisions. Adductor brevis is supplied by either anterior or posterior division of obturator nerve. Obturator nerve emerges out from the medial border of psoas major. Anterior division of obturator nerve lies deep to longus and pectineus, whereas posterior division lies behind adductor brevis. And genicular branch is continuation of posterior division of obturator nerve, and genicular branch enters in the popliteal fossa and supplies the popliteal vessels, and then pierces the lateral popliteal ligament to enter the knee joint. Okay. And occasionally pectineus is supplied by anterior division of the obturator nerve and also by femoral nerve, and thus pectineus has dual nerve supply. Okay. Next is surgical division of obturator nerve. In case of spastic paraplegia causing adductor muscle spasm, surgical division of obturator nerve may be useful to relieve these symptoms. Okay, and referred pain of hip to knee, as obturator nerve supplies both the hip and knee joint, it may cause referred pain to the knee joint. This comes as explained why. This is not that much important. Referred pain, hip to knee. Okay, this nerve is supplying both the hip joint and knee joint. So in case of different abnormalities of hip joint or any injuries or disease condition of hip joint, the pain is also referred to the knee joint. Okay, understood? Accessory obturator nerve, here you can see the accessory obturator nerve. It has a communication with the obturator nerve supplying hip joint and pectineus. So it is present in 30% of individual. It is a branch of lumbar plexus formed by division of ventral primary rami of L3, L4 spinal nerves. Root value is L3, L4. Course, it emerges out of medial border of psoas major muscle on the posterior abdominal wall and descends downward and crosses the superior ramus of pubis anterior to enter the thigh. These are the branches supplies the pectineus, hip joint and gives communicating branch of anterior division of obturator nerve. Next, so we have discussed anterior nerve of anterior compartment and medial. Next we go to the posterior compartment. First to the gluteal region. There is superior gluteal nerve, inferior gluteal nerve, sciatic nerve, posterior cutaneous nerve of thigh, nerve to quadratus femoris, pudendal nerve to obturator internus. Superior gluteal nerve supplies the medius, minimus, tensor fascia lata, hip joint. Inferior gluteal nerve supplies gluteus maximus only. Okay, these two now supply are important. Uh, these muscles you are given in your OSPI question and you will be asked the nerve supply as a related question. Important for your OSPI and Viva. Okay. And sciatic nerve is also given. Very thick nerve you have seen in dissection given in your OSPI. So it does not give any branch in the gluteal region, and posterior cutaneous nerve of thigh, it gives perineal branch for the skin of posterior two-thirds of scrotum and labium majus, and gluteal branches for skin of posterior inferior quadrant of gluteal region. Now to quadratus femoris supplies inferior gemelli, quadratus femoris and hip joint. And pudendal nerve does not give any branch in the gluteal region. And now to obturator internus supplies obturator internus and superior gemelli. Okay, understood? So individual branches we can discuss. Root values are asked in your MCQs, all these nerves. So superior gluteal nerve L4, L5, S1. Inferior gluteus L5, S1, S2. Okay, one segment below. Superior gluteal nerve, branch of lumbosacral plexus, arise from ventral rami of L4, L5, S1, enters gluteal region through greater sciatic foramen above piriformis, and in gluteal region runs upward between medius and minimus, supplies medius, minimus, tensor fascia lata, hip joint. And inferior gluteal nerve, root value L5, S1, S2, branch of sacral plexus, arising from ventral rami of L5, S1, S2, enters gluteal region through greater sciatic foramen below piriformis and supplies maximus only. Okay. Sciatic nerve root value is L4, L5, S1, S2, S3. It is the thickest nerve in the body, course in the gluteal region, enters gluteal region through greater sciatic foramen below piriformis, runs downward and laterally between greater trochanter and ischial tuberosity and continues in the thigh. It does not give any branch in gluteal region. Next, posterior cutaneous nerve of thigh, root value S1, S2, S3. Sciatic nerve root value you very carefully remember, okay? L1 to L4 to S3. Okay, very frequently given in your OSPI question. Beginning and its two terminal division. Two terminal divisions are tibial nerve and common peroneal nerve. Posterior cutaneous nerve of thigh S1, S2, S3 is root value begins from sacral plexus from the dorsal division of S1, S2, S3 nerve, enters gluteal region through greater sciatic foramen below the piriformis, medial to sciatic nerve, runs downward and laterally, enters the thigh, gives branches perineal branch and gluteal branch. Perineal branch for skin of posterior two-thirds of scrotum or labium majus, and gluteal branches for skin of posterior inferior quadrant if in the gluteal region. Now to quadratus femoris, L4, L5, S1 is root value, arise from sacral plexus from ventral rami of L4, L5, S1 and enters gluteal region through greater sciatic foramen below piriformis, runs deep to sciatic nerve and tendon of obturator internus with two gemelli, muscular branch to inferior gemelli and quadratus femoris. Articular branch for hip joint. Pudendal nerve, root value is S2, S3, S4, arises from sacral plexus from ventral division of S2, S3, S4. Enters gluteal region through gluteal, same as the nerve to quadratus femoris. Through the getastatic foramen below piriformis, crosses ischial spine and sacrospinous ligament, leaves the gluteal region through the lesser sciatic foramen and enters the pudendal canal. This is one of the structure of pin structure. Pin structure you remember, pudendal nerve, internal pudendal vessels and nerve to obturator internus. Okay, very frequently asked, Viva, OSPI, MCQs, pin structure. Branches is it does not give any branch in gluteal region. Nerve to obturator internus L5, S1, S2. Beginning arise from sacral plexus from ventral division of ventral rami of L5, S1, S2. Enters gluteal region through getastatic foramen below piriformis, crosses ischial spine, leaves the gluteal region through lesser sciatic foramen. Supplies obturator internus and superior gemellus. Perforating cutaneous nerves arise from sacral plexus and pierce the overlying structures to supply the skin of posterior inferior quadrant of gluteal region. So all these are nerves of gluteal region. So next we go to clinical integration of piriformis muscle. This is very frequently given. Intramuscular injection. Why it is given in the upper and outer quadrant in the gluteal region. Okay, very frequently given. Explain why question. Why intramuscular injection is given. So to save the sciatic nerve during the intramuscular injection. So in the upper outer quadrant of gluteal region is most commonly used quadrant for intramuscular injections, prevents injury to sciatic nerve as it has outer convex course between these 2 points, point A and point B. Here is point A, point B. In between these 2 points it has a convex course. Okay, so if you give the injection in the other quadrants, there is high chance of injury to this sciatic nerve. Okay, and it is a very important nerve for the posterior compartment muscles. So it is injured, there will be paralysis or pain or tingling, numbness, all that will be there. So this point A is 2.5 centimeter lateral to midpoint of the line joining posterior superior iliac spine and ischial tuberosity. Here, midpoint of these 2 points. Ischial tuberosity, posterior superior iliac spine. And point B is midpoint of the line joining greater trochanter and ischial tuberosity. Greater trochanter, ischial tuberosity, its midpoint. This is the curved course, and injections are preferably given in the gluteus medius muscle, okay, not in maximus. Okay, that is also important. We don't give the injection in maximus, we give in gluteus medius. Okay, and to block sciatic nerve block, this is also important. To block the sensation conveyed by the sciatic nerve, anesthetic agent is injected 4 to 5 cm below the midpoint of the line joining posterior superior iliac spine and greater trochanter. Piriformis syndrome, this can come as a short note. Piriformis syndrome, important short note. There will be symptoms. Symptoms are pain in the buttock. Commonly occurs in ice skaters, cyclists, rock climbers. They use gluteal muscles vigorously and causes compression of sciatic nerve by hypertrophied or bulky piriformis muscle or spasm of the piriformis. Okay, this is the cause. See here, this is the piriformis muscle. Okay, there will be compression of nerves in hypertrophy of the muscle. All these nerves are related on the inferior border, and superior gluteal artery and nerve is related at the superior border, and all these are related to the inferior border of the muscle. Key muscle, we have read key muscle of the gluteal region is piriformis. You practice a schematic diagram like this. Okay, this comes as long question. Structures under cover of the gluteus maximus. Okay, this comes as long question from the gluteal region. So for that you can draw this schematic diagram. Understood? All those muscles you have to mention, vessels and the nerves you have to mention, and the bony structures and ligaments also you mention. Understood? This is a sagittal section. All this is piriformis, superior to piriformis, superior gluteal nerve and vessels, inferior to piriformis, all these are coming out. Inferior gluteal nerve and vessels. Now to the sciatic nerve, posterior cutaneous nerve of the thigh, all these are coming out. Okay. So sciatic nerve or ischiadic nerve is the thickest nerve in the body, and it is the largest branch of sacral plexus, begins in the pelvic cavity, exits the cavity through greater sciatic notch, and runs in the gluteal region and back of thigh, and finally terminates by dividing into tibial and common peroneal nerve in the popliteal fossa. That will be popliteal fossa. Okay, cubital fossa is lying in your superior extremity. Width is 1.5 to 2 centimeter. This is the formation. It has two components, tibial part and common peroneal part. Tibial part is formed by anterior divisions of ventral primary rami of L4, L5, S1, S2, S3 spinal nerves, and common peroneal component, it formed by the posterior division of ventral primary rami of L4, L5, S1, S2, S3. This is when anterior division, here is posterior division. Root values are same. Okay. So this is root value. This is very frequently given OSPI question. Extend. Sciatic nerve passes through the following regions: pelvis, gluteal region, back of thigh, up to the superior angle of popliteal fossa. So it passes through these regions. In the pelvis, lies on anterior surface of piriformis, under cover of its fossa, and in the gluteal region enters the gluteal region through the greater sciatic foramen below piriformis. Superficial relations is maximus, long head of biceps femoris. Deep relation from superior to inferior bed of sciatic nerve is formed by body of ischium, tendon of obturator internus with superior inferior gemelli, quadratus femoris, adductor magnus. Medial relations are inferior gluteal nerves and vessels. In the thigh, superficially lies this long head of biceps, deep is adductor magnus, medial is semi-membranosus and semi-tendinosus, and biceps femoris in the middle of the thigh. Okay, so these are the relations. This is sciatic nerve and its course. These are the branches: articular branch to hip joint, muscular branches to tibial part, is supplying semitendinosus, semimembranosus, long head of biceps, ischial head of adductor magnus, and common peroneal part supplies short head of biceps femoris, and these two are the terminal branches: tibial nerves, common peroneal nerve. Okay, so these branches are very very important for sciatic nerve. Branches of femoral nerve and sciatic nerve, and their root values are very very important. So intramuscular injection in gluteal region should be given in upper outer quadrant. To block the sensation conveyed by the sciatic nerve, anesthetic agent is injected 4 to 5 cm below the midpoint of the line between posterior superior iliac spine and greater trochanter. What is sleeping foot? On sitting on a hard surface, sciatic nerve gets compressed against the femur, and it results in numbness and loss of sensation in feet and legs, and this is called sleeping foot. Okay, everyone must have experienced this. Okay, sleeping foot. Sensation resumes back within a few minutes after walking some distance or like this. Sleeping foot. Baker's cyst. Very commonly asked. What is Baker's cyst? Baker's cyst can come as a short note or part of long question. It is known as popliteal cyst. This is fluid collection behind the knee joint, and it is the posterior herniation and cyst of synovial membrane of the knee joint. Okay, named after William Baker, English physician and surgeon. Baker's cyst. This is posterior herniation and cyst of synovial membrane of knee joint. Okay, that is important. Sciatica. What is sciatica? Very, you will see patients of sciatica, very common disease. It is clinical condition that manifests with shooting pain along the distribution of sciatic nerve and its branches. Pain usually begins in the gluteal region and spreads over the back of thigh, lateral side of leg and dorsum of the foot. Okay, this is the distribution of pain. In herniation of herniation of intervertebral disc in lumbar and sacral regions, what are the causes of sciatica? Okay, sciatica, important, explain why or short note. So herniation of intervertebral disc in the lumbar and sacral regions, here disc herniation is occurring, or in pregnancy or in piriformis syndrome, there is compression of sciatic nerve within the piriformis in piriformis syndrome, and pathology is compression of L4, L5, S1 spinal cord. Treatment is based on the cause. Most of the cases recover in a few weeks to months and may require rest, physical exercise, and NSAIDs. Okay, non-steroidal anti-inflammatory drugs. In severe cases, discectomy may be required. This will be the treatment. Discectomy is removal of the intervertebral disc. Okay. So sciatic nerve is thickest nerve in our body, easily identified in gluteal region under cover of maximus, gluteus maximus, in the thigh crossed by long head of biceps femoris, and the variation in the level of terminal division. Sciatic nerve is very common variation. It may have high termination even in the pelvic cavity itself. Okay, then these two components will come out separately. Tibial and common peroneal component will come out separately below the piriformis if high division occurs. All the muscular branches of sciatic nerve arise from its medial side except for short head of biceps, and that arise from lateral side. Hence surgically the lateral side of sciatic nerve is safe side. What is artery and nervis CRDC? This is asked in your OSPI and Viva. It is a small artery that accompanies the sciatic nerve and branch of inferior gluteal artery. It is a part of axial artery of the lower limb. Okay. Axial artery of lower limb, it is an embryological structure, is represented in adult life by arteria comitans nervis CRDC, part of popliteal artery above the popliteus muscle, distal part of peroneal artery and part of plantar arch. Popliteal pulse. It is difficult to palpate as lies deep and covered by strong popliteal fossa. On the posterior aspect of the knee joint, you have to palpate this part. Popliteal pulse you have to palpate in your final year medicine. Okay. So to palpate the pulse, you have to flex the knee to relax the popliteal fossa and hamstring muscles and feel the pulsation by pressing deep against the lower part of femur. Absence of popliteal pulse indicates compression of femoral artery. Okay. Popliteal artery hemorrhage occurs due to trauma to popliteal artery, mostly due to knee dislocation and leads to popliteal artery hemorrhage. And entrapment syndrome, popliteal artery entrapment syndrome, artery runs and variations in the origin of gastrocnemius may lead to popliteal artery entrapment syndrome produces intermittent claudication, that is pain due to insufficient blood supply in the leg. Next, it is already 10. Okay, so you complete, also read the applied aspects of tibial nerve, common peroneal nerve, and in the sole of the foot. Okay, I will, these are the, you have read already branches. This beginning, last terminal branch of sciatic nerve, root values are important. All these are given. These are thick nerves, tibial nerve, common peroneal nerve can be given in your OSPI. Have to identify the structure and write down the beginning, termination, branches, all these are important for tibial, common peroneal. Okay. Sural nerve, it leaves the popliteal fossa by piercing the deep fossa at the inferior angle of fossa and supplies the skin of lower half of back of the leg at the lateral border of the foot till the toe. Common peroneal, smaller terminal branch, root values and branches are important. Branches are deep peroneal, superficial peroneal. Superficial peroneal supplying peroneus longus brevis and tertius in sometimes, and tertius is supplied anterior by anterior compartment, deep peroneal nerve. So branches are important for this. Dorsalis pedis artery, this is where you will feel it. An absence of dorsalis pedis artery occurs in 14% of cases, and in peripheral vascular disease or Burgess disease also it is absent. Okay, so for peripheral pass you have to feel dorsalis pedis. If it is absent, then palpate for popliteal artery pulse. Then this is again absent, then you have to palpate for femoral arterial pulse. Okay. So Burgess disease, what is Burgess disease can come as a 2 marks or question like this, part of long question. Or thromboangiitis obliterans, progressive inflammation and thrombosis, clotting of small vessels of hand and feet, especially in smokers, result in diminished or absent peripheral pulsation, reduced blood supply to limbs, pain in the affected areas. Deep peroneal nerve, also have to know the supplying anterior compartment, leg and dorsum of the foot, root values and supplying areas are important. And division occurs at the lateral side of neck of fibula. Common peroneal dividing into superficial and deep peroneal. Okay. So read the nerve supply and supplying areas. And this cutaneous supply is important. So all these nerves are important for your long question. There are foot drop. Foot drop occurs in injury of deep peroneal nerve. That is important. Explain why. Okay. And sensory loss. Where will be the sensory loss? Fresherman's nerve. And tendon grafting we do for plantaris tendon. Plantaris and peripheral heart. Why soleus is called peripheral heart? Important. Explain why. Okay. And tarsal tunnel syndrome, here there is compression of tibial nerve, like the carpal tunnel syndrome, compression of median nerve, tarsal tunnel syndrome, compression of the tibial nerve. Okay, so all these are important for your questions. Okay, that's all. Thank you.